Good morning and welcome everyone to today's Global Grand Rounds. My name is Ghoncheh Angha and I will be your host for today. Before we start, I'd like to go over a few things. The presentation is being recorded and will be uploaded to our YouTube channel. I am turning on our feature. If you need to turn on the feature called closed captioning during the presentation for subtitles, you can see it at the bottom of your screen. And I've provided relevant in our chat for you to look through. And I will hand it off to Dr. Pekia, who will be hosting our Dr. Suleman from Buganda Medical Center today.
Thank you, Ghoncheh, and welcome everyone. First of all, a bit about Ghoncheh, who is our director for many years at Global Offsite Care and has done great work for us for a long time. And Ghoncheh, thank you this morning for being here and running the show. Dr. Suleman, Tanzanian emergency medicine specialist and academic leader. She serves as the head of the emergency department at Buganda Medical Center in Mwanza, one of Tanzania's key referral and teaching hospitals. In addition to her clinical leadership, she holds the position of senior lecturer at the Catholic University of Health and Allied Sciences, where she plays a crucial role in the training of the next generation of healthcare professionals. Her contributions to both clinical practice and medical education continue to have a significant impact on healthcare delivery in Tanzania. Beyond her roles at BMC, and Dr. Shahzmah is the Vice President of Emergency Medicine Association of Tanzania, where she actively engages in national and international collaborations aimed at enhancing global emergency medicine. She has participated in academic exchanges with various international institutions, contributing to cross-cultural medical education and advancing emergency care practices. In this presentation, Dr. Shahzmah Suleman will discuss the case of a 10-year-old girl who sustained blunt abdominal injury after a fall, resulting in abdominal pain and hematuria, that's blood in the urine, and was ultimately diagnosed with a grade 4 renal injury requiring a left nephrectomy or removal of her kidney. The case highlights the challenges in diagnosing peds trauma and the importance of serial assessments and the potential role of telemedicine in improving trauma care. And in my role as Medical Director of Global Offsite Care, I am honored to welcome you, Dr. Suleman, and thank you in advance for being with us this morning. With that, I'll hand it off to you.
Thank you so much. I'll just pull up my presentation real quick. All right. I hope everybody can see my screen. Good morning, everyone from the US side, and good evening, everyone from the Tanzanian side. So thank you for your introduction, a very generous one. So as I've been introduced, I'm an emergency physician and I've been the head of the emergency department. This is my 8th year now in leadership. And I also am the senior lecturer at the teaching university, the Catholic Health and Allied Sciences. In addition to that, I also have an MPhil degree in global emergency care from the University of Cape Town, which I actually completed just last year. So we'll straight go to the case. So it is the case of a 10-year-old female. She first presented to the emergency department after having fallen down into a pit, which was about 2.5 meters deep, and she sustained blunt injury to the left side of her abdomen. She was rescued almost immediately from the pit, and she presented to the ED 3 days after actually sustaining the injury. And thereafter, she presented to the emergency department twice more in the subsequent 11 days. The case that I'm going to present was documented on the 3rd visit. We had the parents of the child as the informants, and prior to her presentation, she had no other illnesses reported. So she first came in, and this is a slightly older case, but very interesting, and that's why we're putting it on the presentation. So she first presented to us on the 19th of September last year, and her main complaints were abdominal pain and blood in urine. Upon assessment, she had mild generalized abdominal tenderness, no rebound tenderness or guarding for the abdominal exam. She had fairly stable vital signs. Her extended fast exam, as we do for any trauma patient, was negative, and she had to undergo a formal ultrasound, which was negative for any solid organ damages. And so after consultations from various departments, the patient was discharged home on analgesics, thinking that it was probably just a regular soft tissue injury. She came back 11 days after the injury, and this was obviously 8 days after the first visit. Again, she had complaints of abdominal pain. It was not very clear whether the blood in urine was asked, was it reported, or was it missed from the previous assessment that was done. So in this assessment, she had, again, stable vital signs. Her extended fast exam was still negative. There was no free fluid in the abdomen. And she had mild left upper quadrant tenderness without any rebound or any guarding. And her formal ultrasound was still inconclusive. So it wasn't able to tell us whether there was any solid organ injury or not, but there was definitely no free fluid in the abdomen. So again, after consultation with the pediatric surgery and urology departments, the patient was discharged home on analgesics. She came in 3 days after her second visit, and this time now she presented with abdominal pain. She had total hematuria, and she was also in hypovolemic shock. She had generalized abdominal tenderness this time. She had rebound tenderness as well as guarding. Her extended fast did not show any free fluid. However, the provider who was performing the fast exam noted some irregularity in the morphology of her left kidney, and there was also a homogeneous opacity that was seen in her urinary bladder. So these were some of her lab work. The first visit, except for the elevated white cell count, pretty much normal blood counts she had. On her second visit, her hemoglobin had slightly dropped, and her white cell count had also come down, but her platelet count had slightly increased. And then on her third visit, which was the visit that she presented in hypovolemic shock, her white cell count was 17. Her hemoglobin was raised, and platelets were within normal range. As far as her chemistry results were concerned, in the first visit, the electrolytes were not checked for, but her kidney function and her blood urea nitrogen, so serum creatinine and blood urea nitrogen, were all within normal range. They were also within normal range for the second visit, but in the third visit, she had a slight elevation of her serum creatinine. Otherwise, the other lab results were pretty much within normal range. So this was her right kidney as part of the right kidney and the liver as part of her fast examination. We can see that there is no free fluid in the Morrison's pouch. This was what her left kidney looked like, the splenorenal fossa, so we can clearly see that there is some abnormality on the side of the kidney, and the morphology is not as we would expect to see it. And then this was what her urinary bladder looked like. So this was the homogeneous opacity within the urinary bladder, and this is the urethral catheter that was introduced. So one thing which was very interesting was, despite having a urethral catheter, this patient was still getting episodes of urinary retention within the emergency department, and she would scream in pain. And that was what we thought was because of this opacity which was here, and we thought that this was the clot of blood that was collecting in the urinary bladder. So having the balloon in there, in the urinary bladder, and the clot was causing her episodes of urinary retention. The patient did undergo a CT scan of the abdomen. This was a contrasted image. So I've just taken up one of the images, one of the slices. And this is what the right kidney looks like, but the left kidney is not uptaking any contrast whatsoever. And definitely there was damage to the left kidney. So some of our diagnosis, obviously shock due to hemorrhage, was on the top of the list. And after having visceral injury was one of the diagnoses, but after having confirmed with the CT scan, we ended up having renal injury as our confirmed diagnosis. We also had a preliminary diagnosis of a retroperitoneal hematoma, and that is why it was very difficult to get it on the FAST exam in the first place, and a urinary bladder hematoma. So those were our 4 diagnoses that we had within the emergency department. So what ended up happening to the patient? She was admitted on the same day that the final visit that she presented on, and she was operated further 2 days later. So it was actually 16 days after sustaining the injury she was operated on. She had to undergo a left nephrectomy because of a grade 4 renal injury, and you can see on the image, this is what the kidney looked like. And she was discharged from the hospital. She is doing well post-surgery. She has attended now more than 2 follow-ups and has had no complications so far. The kidney was sent for biopsy just to make sure that there was nothing that we were missing, and it revealed that there were renal vessel thrombi and hematoma with parenchymal necrosis that was found on biopsy. So we have a little bit of literature which supports some of the things that we have seen in this patient. Blunt abdominal injury is one of the most common causes of injury in children, and it is also responsible for over 90% of kidney injuries in children. And this was reported in a study in Iran in 2021. In Senegal, on the other hand, road traffic accidents are common cause, with abdominal pain being present in majority of the patients who presented with abdominal injuries. Elevated white cell count was found to be one of the predictors of occult injuries in blunt abdominal trauma, although it may not predict the severity of injury, and this was reported by Ibrahim et al. In 2019. And the elevation of the white cell count is basically because of the body's response to the trauma and inflammation. So what are some of the learning points that we can take home from this case? Renal injuries are mostly due to blunt abdominal trauma. Blunt causes are the most common. And this is because children physiologically have larger kidneys. They are more superficial and they're less protected by surrounding structures. And so they are more prone to injuring the kidneys by blunt trauma. Diagnosis definitely can be challenging, especially in the settings of limited resources where there is a difference in knowledge in ultrasound. Solid organ injuries like this one that were contained may not necessarily have free fluid in the peritoneum. The ultrasound itself is very user dependent, and despite having done a CT scan from the emergency department, the interpretation of the CT scan itself, whether it's the surgeons or the residents from the surgical department, is also varied, and therefore it may pose a challenge in diagnosing blunt kidney injuries. And also, eventually, the experience of the provider also matters in scenarios like this. And conservative management is definitely considered in certain kidney injuries in children. However, it really depends on whether the patient is hemodynamically stable or not, and that applies mostly to lower grade injuries. So if this injury was diagnosed early to be a grade 4 injury, maybe the patient would have been operated earlier on. So what is the role of telemedicine now? If we have to talk about scenarios like this was a patient that was referred from home, but suppose this is encountered in other hospitals, lower level facilities, then what do we think is the role of telemedicine? It will definitely help in remote evaluation of the symptoms. Telemedicine does provide the access to specialist experience, and so that consultation can provide a lot of value in the management of children with blunt abdominal injuries. It also does support in diagnostic decision-making in terms of imaging. So if we have telemedicine on board, there is a provider who is able to perform the abdominal examination using the ultrasound, and the images can be shared in real time, then certain diagnostic decisions can be supported. It also does provide guidance and training in recognizing signs of early pathology. And it also assists with post-injury follow-up. So if a patient was eventually referred and they go back to their hometowns or home villages, then telemedicine can assist with some of the follow-up communications. But as we all know, in limited resources, there are always limitations of telemedicine. And the biggest thing is the reaching a definitive diagnosis when you do not have the actual patient contact. That can sometimes pose a challenge. But then there is also digital literacy and infrastructure, which may not be very reliable in certain areas, and that can pose a challenge. And certain subtle signs, despite the fact that a consultation may have been placed online, because of in-person examination, some certain signs may be missed in patients. So with that, we come to the end of the presentation. If there are any questions, we can welcome them.
Great. Thank you, Dr. Suleman. That was excellent, concise, and presenting a case I think that is really not only helpful for this particular type of presentation, but in general, how taking some of the new technologies that support telemedicine and clinical decision-making that can help us all elevate what we do for our patients and the communities that we serve. Thank you so much for that.
Thank you.
While everyone else gets their questions ready, Ghoncheh, should I start with the first question?
Yes, please, Dr. Pekia.
Okay, great. Yeah, having a bias myself in my role as wearing my hat at Western University of Health Sciences in Pomona, California, and director of telemedicine and the courses, the clinical courses and the didactics for that at Western U, which, by the way, is graduating its next class of doctors, I think 330 or so doctors at our two campuses, and many of whom will be viewing this after their celebrations today. Kudos to them. And many of them, by the way, are training and have been accepted to residencies in emergency medicine in the U.S., and I think we'll have particular interest in this topic. So my first question is on the telemedicine side and also on the use of artificial intelligence. I'm curious, in your experience, has the use of AI in some of the new technologies of AI summarization, very much the AI companion that's running as we speak in this meeting that will summarize the meeting and then turn it into a bullet point version of the meeting. We're using these platforms at scale now in the U.S. Would the presence of that or the availability of that in the clinic, in the ED, would that help support diagnostic decision making, both on the imaging side and also on the data element side, specific in this case to, I think you mentioned that hematuria may or may not have been identified or at least documented earlier on in the course of this patient. Yeah, is AI actually yet in use in your experience, and has it been helpful to this point?
Okay, AI in our institution has not been used yet. And I think mainly it is because of the lack of technology, if I may put it that way. And maybe we're still not built enough to use it. And that is because we're not against AI in any way, but it's mainly because I feel that there is so much more technological advancement that is still needed before we actually get to the point of using AI, because there is still a lot of competencies that I feel in our settings, limited resource settings, that we need to first get a hang of before we can actually move to AI to help out with some of these diagnoses. Having said that, it's not necessarily like a no, but it may not be feasible in certain levels of healthcare, whereas in more advanced levels of healthcare, it may still be something that can be used. So if I was to talk about like the referral pyramid that we have in our country, so slightly higher levels, or like the zonal referral, the national level hospitals may have the technological advancements necessary to incorporate AI to be able to assist with some of the diagnosis, but not necessarily in the slightly lower level health facilities. So right now I am at one of the district hospitals within Mwanza region, still far away from the city. And just using the ultrasound to perform the FAST exam is still a challenge. And so we are working on building that capacity. And that is what I mean by saying that we may not necessarily be there yet, but that doesn't dismiss it entirely.
Great. Thank you. And that's helpful. And as I think, as you mentioned, certainly a work in progress. There's a ways to go. I think especially for leaders and experienced clinicians who are right to, as this capability comes slowly on board, to be sure that it's fully developed as much as anything can be in healthcare and demonstrates its utility for benefiting assessment of cases like this and others. So thank you for that. Okay. Any other questions, comments? I don't know if we have anything in the chat, but I'll step back here for a moment and welcome any other questions or comments.
I have a question. So when you're bringing in telemedicine for when the patient's gone home and how it could be a very useful resource, when needing like diagnostic or labs, do they go to like their local clinic if there's one, or will the doctor go to like the patient at their home? Is that possible? How is it that you can do patient follow-up with telemedicine when they go back home? What are the procedures in place or resources in place for them closer to their home?
Okay, so for now, we don't have anything formal in place, but it's definitely work in progress because there are limited resource settings like Mexico. I know they do have some level of telemedicine follow-ups for some of their diabetes and their hypertension patients. So they use the community health workers, give the resources to the community health workers to then follow up with the patients at home. So this is in the setting when they do not require maybe lab testing or like they don't physically need to be in the hospital for a certain procedure. In the event they do, then potentially, and this is a thought when we get to that point, would be to like have set up for them to, on an appointment basis, like to be able to access that specialist care in the hospital while they come in for their medication refills or lab tests, so that they get the benefit of at least having a specialist review in settings where they may not necessarily have access to one. So within the hospitals, setup could be initiated, and then the community health workers could be used for other scenarios to just provide that care within the comfort of their home.
Nice. Very nice. Yeah, Global Offsite Care and Buganda, we've worked together and made other hospital connections at Bukoba and Sharati to help link up these lower resource communities, and always looking to connect more. So if you're aware of any sort of areas around Buganda that could benefit from us, Global Offsite Care, helping and establishing some means of imaging in lab or whatever we are capable of doing, we would love to be able to continue supporting Tanzania in that way.
That would be amazing. I think the biggest thing that I actually love and wish that more and more people can use is the ultrasound, because it's so cheap.
Yes.
And with just a little bit of training.
Yes,
it does so much with a little bit of training. And so I believe that there is still a big role that we have building that capacity.
Yes.
And it will definitely help as the country is putting in a lot of effort in the healthcare system to bring that capacity, bring those equipments and technology. But I feel by the time we get there, I think the knowledge of the ultrasound is just immense, and we can use it in a very positive direction.
Yeah, absolutely.
Because majority of the district level hospitals will not have a CT scanner. They might not have a radiographer off working hours. So it really entirely falls back on someone who is on call to be able to make that diagnosis. Yeah. So I think that's an essential thing that is cheap and easy to work on, actually.
Yeah. And do your doctors receive training for ultrasound so that if probes were provided, I think a biggest hurdle is the training aspect of it. So.
That can be arranged for sure. There is a project that we are working on, slightly lower scale, and we want to see how that goes. And If it does go well, then it could be a good potential to escalate from there. So
Nice.
there is a focus curriculum. There is one developed by the Emergency Medicine Association of Tanzania. They have a focus curriculum in collaboration with the Muhimbili University. But there are like individuals that we have also, doctors who train in ultrasound, who train providers in ultrasound, and like OB ultrasounds, abdominal ultrasounds, the fast exam, the cardiac exam, the lung exam, because radiology is not a luxury in a lot of the places. And so when getting a chest x-ray is sometimes difficult. And so knowledge in ultrasound definitely becomes handy in those scenarios.
Yes.
Yeah.
Thank you.
Yeah, and then additional perspective on that is, first of all, to recognize that may or may not know that Ghoncheh has actually, as you mentioned, been out to remotest Tanzania in the little village of Shirati a couple of years ago. And by the way, she's a newly minted small aircraft pilot. You recently completed that, is that correct?
In December yes. And I'm actually going to start full-time at Airline Transport Pilot School, ATP school. In 7 to 9 months, I'll have the 5 more licenses I need to then build my time as an airline pilot.
Wow.
That's amazing.
Yeah, so I'll be transitioning my career as a chemist in the lab to a pilot in the air. So I would love to come to Tanzania. I've even talked to Dr. Chirangi at Shirati Hospital. He said there's a little airstrip behind the hospital, and I actually am very much looking forward to the possibility of being able to be a bush pilot in Tanzania, bringing medical supplies, oxygen, patients, doctors around the country. Yes, so definitely looking forward to this in my future. I know that Tanzania and global offsite care had to merge somehow in my future, so I see it will happen.
Wow, amazing.
Yeah, so I think that's a good example of some of the great ideas turn into solutions from conversations, sometimes similar to this and events like this. Is it out of the realm of possibility that we can find an intersection of what Ghoncheh's remarkable path is leading her to, and the need on the ground, whether it be in Tanzania or other places that are very often under-resourced. Same thing in the United States, right? The more rural you get, the less likely it is that folks that get sick or injured in those places necessarily always may not have access to the kind of care that we can now fly out to those areas, handheld ultrasound being one of them, and also that we now have stable bandwidth, internet bandwidth at places like that, satellite internet, etc., and 5G, LTE, cell phone connectivity out in remote places. And lo and behold, as we speak, some of those handheld ultrasound companies, one of which we've been working with for years, will give some kudos to Butterfly IQ,
yes,
which is well known in the emergency medicine world globally, and that they have been working for years now on basically AI interpreted ultrasound, so that for places that don't have access to radiologic interpretation, that they now have and already market and are already using a thing called AI caption, and that essentially interprets immediately not only the validity of the ultrasound that's being obtained, essentially this is a good image that can be interpreted, but at least in open markets for a nominal fee, that the interpretation can be generated immediately using an algorithm that's also uses a large language model, otherwise known as AI, to at least give level 1 interpretation immediately if there isn't a radiologist available to interpret it. So that a case like the one presented today maybe would be offered the opportunity to be more immediately diagnosed, really wherever that individual may be. And it may not be in an emergency room, maybe in a little clinic, Shirati. So we're close. I think we're close enough finding that sweet spot, if you will, to share our experience and understand our knowledge and our relationships to get on with it, so that when Ghoncheh is able to take her next trip in her own aircraft, or at least given the opportunity to make that happen, that we're ready to support her in that way and work together. So
thank you.
Yeah, you got it. Okay, any other questions out there? and
Butterfly.
comment.
There's the butterfly, yes.
There we go. Perfect.
See how handy it is? It's just
Very. Very.
Yeah. And with a little bandwidth and a little bit of cloud-based AI, next thing you know, we can be helping to transform the care of lots of people that very often find themselves on the wrong side of the social determinants of health. Yeah. Well, Ghoncheh, are we close to
there's
closing?
no questions. Just one more shout out. If anybody has any last minute questions before we conclude today's meeting, you can either drop it in the chat or unmute yourself and ask Dr. Suleman directly, or anybody else here on the team if you've heard anything you'd like to ask more about. Thank you, Dr. Suleman, for your presentation today. I'm so honored to be hosting today's meeting with you. I'm so happy to see you. We have the recording of our presentation will be uploaded to our YouTube channel in a couple of days. And if you are interested in seeing our Global Grand Rounds next month, June 11th, please sign up for an invitation.
Perfect.
And we appreciate your participation today. We hope to see you again next week. Thank you so much.
Thank you so much. Thank you.
Thank you.